discuss neonatal hyperbilirubinemia, and especially we will be focusing on congenital hyperbilirubinemia, what are its causes, and how you investigate a patient with conjugated hyperbilirubinemia. And we will be discussing the different causes of conjugated hyperbilirubinemia. But before discussing conjugated hyperbilirubinemia, we should first know what is neonatal hyperbilirubinemia. As the name indicates, neonatal. So it is the first 28 days of life we are talking about, that the jaundice started in a baby within first 28 days of life. Neonatal hyperbilirubinemia, and the bilirubin is more than that is normally present in the blood. So neonatal hyperbilirubinemia is a condition in which the baby is having increased amount of serum bilirubin in the blood. Hyperbilirubinemia is an increase in the serum bilirubin characterized by jaundice. And as you know, jaundice is a yellowish discoloration of the skin, sclera, and mucous membranes, which is rarely perceptible until the serum bilirubin level exceeds 5 milligram per deciliter in neonates. In adults, you can see the raised serum bilirubin, you can see the jaundice up to 2 milligram per deciliter. But in neonates, when the serum bilirubin level exceeds 5 milligram per deciliter, then only it becomes clinically visible, and which is yellowish discoloration of the skin, sclera, and mucous membrane. And for looking for jaundice, it is recommended that one should examine the baby in the daylight, because in artificial light it is difficult to judge whether there is mild jaundice present or not. So to be sure, it is always recommended that when you are checking the baby for jaundice, you take the baby to a place where the daylight is available. Most newborn infants experience some degree of jaundice. Most jaundice is benign, but because of the potential for bilirubin toxicity, newborn infants must be monitored to identify those at risk for excessive hyperbilirubinemia, treated appropriately, and followed up by experienced perinatal healthcare professionals. So in most of the cases, jaundice is benign and to get better, and but in some cases it is pathological, and in that case one should be able to diagnose it at the proper time and treat it properly to prevent the child from the consequences. Now, before going to the detailed discussion regarding the cholestatic jaundice or conjugated hyperbilirubinemia, it is important to understand the basic activity, how the normal bilirubin mechanism is in the body. Porphyrins combined with the iron to form heme. This heme combines with globin to form hemoglobin. This hemoglobin is incorporated in the red blood cells, and the red blood cells are then from the bone marrow enter into the blood circulation, and usually they complete their life about 120 days. And after completing their life, when they become old, in the reticuloendothelial system, the old RBCs are broken down, and the hemoglobin is further broken down into three pieces. Iron goes to the iron pool, globin goes to the globin pool, and rest of the heme that is left is acted upon by heme oxygenase enzyme, and it converts that into heme into biliverdin. Then there is another enzyme which is called biliverdin reductase that converts the biliverdin to bilirubin, and then this bilirubin comes out of the reticuloendothelial system into the blood, where it binds with the albumin, and this bilirubin albumin complex reaches the liver, and then the bilirubin enters into the liver and enters into the smooth endoplasmic reticulum, where it is conjugated to and now it becomes conjugated bilirubin. Initially it was unconjugated, now it becomes conjugated bilirubin. This conjugated bilirubin is water soluble and it excreted into the bile, and when through the common bile duct it reaches the intestine, it get hydrolysis takes place, and some of that conjugated bilirubin converts into bilirubin, and that bilirubin through the enterohepatic circulation, some amount of it goes back again to the liver, where again it is conjugated. So this is called enterohepatic circulation, and some amount of bilirubin gets circulated like that. Majority of it is acted upon by the bacteria present in the gut, and it converts it into urobilinogen. Some of the urobilinogen enters into the blood, enters into the blood and gets excreted through the urine. That is called urinary urobilinogen, and some of gets through the portal circulation to the enterohepatic circulation, reaches the liver and gets conjugated, and then comes into the again the same. Some of the urobilinogen gets excreted as stercobilin in the stool, and that gives the color to the stool, which is usually yellowish brownish. So this is the thing that we should know. And some amount of heme also comes from heme precursors, myoglobin, non-hemoglobin heme precursors as well, but mostly the heme is coming from the destruction of the old RBCs. Now, there are two types of hyperbilirubinemia. One is called physiologic hyperbilirubinemia, and another is called the pathologic hyperbilirubinemia. Physiologic hyperbilirubinemia is increase in bilirubin by the second day of life. It declines by the fifth day of life. Onset and resolution may be delayed in premature infants. That is, the jaundice, physiologic jaundice may appear on day 5 in premature babies, and it may take up to 14 days to get cleared. So generally speaking, in a full-term baby, the jaundice appear on the second day of life and usually declines by 5th day of life. But in premature babies, there could be some delay in the onset and resolution. That is, onset may be up to 5 days of age and resolution may take up to 14 days. Then comes the pathologic jaundice. Apparent jaundice in the first 24 hours of life. So this is a very important thing to remember, that if the jaundice develops within the first 24 hours of life, it is pathological until proved otherwise. Second, total serum bilirubin level in cases of pathologic jaundice increase by more than 5 milligram per deciliter per day. For example, if you do the serum bilirubin level on day 1, it is 5, and on day 2, when you do, it is 11. You can say, sir, in the last 24 hours, the bilirubin has increased by 6 milligram per deciliter, and by definition, if the serum bilirubin level increased by more than 5 milligram per deciliter, this is a point in favor of pathologic jaundice. So this is the second point in favor of pathologic jaundice. First, if the jaundice appear within the first 24 hours, or if the rate of rise is more than 5 milligram per deciliter per day. And third, total bilirubin level in usually in cases of pathologic jaundice is more than 12.5 to 15 milligram per deciliter. Regarding the direct levels are usually up to 1.5 to 2 milligram per deciliter. If it is more than 1.5 or 2 milligram per deciliter, then it will be considered as increased direct hyperbilirubinemia. Persistent jaundice. What is the definition of persistent jaundice? If the jaundice persists beyond the first week of life in the full-term infant, or beyond the second week of life in the preterm infant, this is considered as persistent jaundice. And the causes of persistent jaundice are hepatitis, biliary atresia, Down syndrome, hypothyroidism, etc. Now, regarding the neonatal cholestasis. Neonatal cholestasis is defined as conjugated hyperbilirubinemia developing within the first 90 days of extrauterine life. Conjugated bilirubin in these cases exceeds 2 milligram per deciliter, or conjugated bilirubin generally exceeds 20% of the total bilirubin. For example, if the total bilirubin is 10, and if you see that conjugated bilirubin is 3, you say it's 30% of the total bilirubin. So it is conjugated hyperbilirubinemia. So for defining someone as having conjugated hyperbilirubinemia, you need that out of total bilirubin, the direct bilirubin or conjugated bilirubin should be more than 20% of the total bilirubin. If it is more than 20% of the total bilirubin, you consider this patient as having conjugated hyperbilirubinemia. Now, regarding the neonatal cholestasis, conjugated hyperbilirubinemia is divided into two types: extrahepatic causes leading to conjugated hyperbilirubinemia and intrahepatic causes leading to conjugated hyperbilirubinemia. Usually those causes that causes conjugated hyperbilirubinemia of extrahepatic type, they come under the domain of pediatric surgeon. And those babies who are having conjugated hyperbilirubinemia because of some intrahepatic causes, they come under the domain of a pediatrician or a physician. Now, let us first discuss about the extrahepatic etiologies. In this comes extrahepatic biliary atresia, choledochal cyst, bile duct stenosis, spontaneous perforation of the bile duct, cholelithiasis, inspissated bile/mucus plug, extrinsic compression of the bile duct. So these are the examples of extrahepatic etiology. Now we talk of intrahepatic etiologies leading to cholestatic jaundice. Could be idiopathic when you don't know the cause, or it could be toxic, or it could be genetic/chromosomal reason. It could be infectious in origin. It could be metabolic in origin, and there could be miscellaneous cause for intrahepatic cholestasis. How a baby with conjugated hyperbilirubinemia will present? You will examine, when you examine the patient, you see that the baby is having jaundice. There will be scleral icterus. You palpate the abdomen and you find that the liver is enlarged. There is hepatomegaly. And when you examine the stool of those babies, they will be echolic stools, meaning they will not be having the yellowish or brownish color that usually you see in baby's stool. It will be white in color. And when you examine the urine of those babies, that will be dark urine because of the presence of increased amount of conjugated bilirubin in the urine. Other signs and symptoms depend on a specific disease process. But general things that you can see in all patients in which there is conjugated hyperbilirubinemia, you will be looking for jaundice, scleral icterus, hepatomegaly, echolic stool, and dark colored urine. Goals of timely evaluation: diagnose and treat known medical and/or life-threatening conditions. That is the first goal, to diagnose and treat known medical and/or life-threatening conditions. Second goal is identify disorders amenable to surgical therapy within an appropriate time frame. As we will be discussing in cases of biliary atresia, that if it is diagnosed early and treated properly, then the prognosis is very good as compared to when you diagnose biliary atresia late. So it is recommended that if you diagnose biliary atresia before 8 weeks of age and treat this condition, the chances of survival are much more as compared to when you diagnose biliary atresia after the 8 weeks of life. That is the second objective: identify disorders amenable to surgical therapy within an appropriate time frame. And third, avoid surgical intervention in intrahepatic diseases. Another reason of evaluation is that if the cause, for example, cholestatic jaundice, is a torch infection, or for example, bacterial hepatitis, in that case, naturally, there is no role for surgeon to intervene. So one should know what is the cause of conjugated hyperbilirubinemia in this baby. So suppose it is a medical cause, then the physician should be taking care of, and if it is a surgical cause, then the pediatric surgeon should come into the picture. This is a healthy newborn baby born, and after a few days you notice that the baby developed jaundice. Now the question is, why this baby has turned into yellow color? One reason could be that this patient is having increased bilirubin, and mostly it is unconjugated type of bilirubin. Or the another reason of the jaundice could be that this patient is having conjugated hyperbilirubinemia, plus minus unconjugated hyperbilirubinemia. So there are two varieties. In one condition, there is increased amount of indirect bilirubin, and which is called unconjugated hyperbilirubinemia, and in other variety there could be conjugated hyperbilirubinemia. So you have to look for it. When you do the serum bilirubin level, you look for example, serum bilirubin is 10, and the direct is only 1. So you will say it's predominantly indirect hyperbilirubinemia. But if you see the total serum bilirubin is 10 and 4 is direct hyperbilirubinemia, you will say, as it is 4 out of 10, that's 40%. If it is more than 20% conjugate, then that is called conjugated hyperbilirubinemia. So you will say, as in this patient, out of total bilirubin, the percentage of conjugated bilirubin is more than 20%. So this is a patient with conjugated hyperbilirubinemia. So it's very important, whenever you see the serum bilirubin report, you should decide whether this baby is having conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. Regarding the causes of unconjugated hyperbilirubinemia, most common is the physiological jaundice that you see in healthy term babies, and usually that settles in few days time. Another reason of unconjugated hyperbilirubinemia could be breast milk jaundice. And another very important reason for unconjugated hyperbilirubinemia is jaundice due to RH incompatibility or ABO incompatibility. And another reason of unconjugated hyperbilirubinemia could be hypothyroidism. While in those babies where you diagnose that the out of total serum bilirubin, the direct bilirubin is more than 20%, and this patient is having conjugated hyperbilirubinemia, what you will be seeing that the urine will be of dark urine color, and color will be much darker as per normal color, and the stools will be clay colored stools, meaning not having yellowish or brownish discoloration as the usually normal stools have. They will be somewhat whitish in color. This is how urine of a patient with conjugated hyperbilirubinemia looks like. And this is how the stool looks like. And if you look into the causes of conjugated hyperbilirubinemia, you will be on examination, you will be looking for hepatosplenomegaly, and you will be looking for, in the urine, you will be looking for increased amount of bilirubin in the urine. And when you check the blood, it will be showing you conjugated hyperbilirubinemia. And when you do the liver function test, they will be abnormal in patient with conjugated hyperbilirubinemia. Now, how to evaluate a child who is having conjugated hyperbilirubinemia? Once you do the serum bilirubin level and you know that, yes, I am dealing with a patient who is having conjugated hyperbilirubinemia, how you are going to proceed? The basic evaluation is to take a history of the patient, appearance of jaundice, and when it appeared, how for the last how many days it's persisting, and you do the physical examination. in which you look for hepatosplenomegaly, any petechial rash, or cataract, or any other stigma of any syndrome. And you also look for the stool color as well. Then you do the complete blood count, CBC, and reticulocyte count, and you check the electrolytes, blood urea nitrogen, creatinine, calcium, phosphate, and you do the liver function test, in which you look for SGOT, SGPT, gamma GT, alkaline phosphatase, and they are usually increased in patient with hepatitis. And you check, also look for total and direct bilirubin, and you also look for serum proteins, that whether the proteins are normal or low, and what about the albumin, cholesterol. And you also look for the whether the prothrombin time and activated partial thromboplastin time, APTT, is normal or deranged, because in majority of cases of cholestasis, the prothrombin time gets increased. Regarding the infectious causes of conjugated hyperbilirubinemia, you check for the blood culture. You send the blood for culture and sensitivity. You send the urine also, and you do the CSF. And beside this, you also do the torch titers. Torch stands for toxoplasmosis, other viruses, R for rubella virus, C for cytomegalovirus, H for herpes virus, and VDRL, venereal disease research laboratory test, that is done for syphilis. And you also check for urine for cytomegalovirus. And also you do the hepatitis B surface antigen test and hepatitis B core antibody IgM, and you also do the anti-HCV to see whether this cause of jaundice in this newborn baby is related with either hepatitis virus. And you also do the ophthalmological examination. Beside this, for looking for the metabolic causes leading to cholestasis, you do the protein electrophoresis, alpha-1 antitrypsin level, and its phenotype. And you also look for thyroid function test. You do the sweat chloride test to find out whether this patient is having this jaundice because of cystic fibrosis, or you check the urine and serum amino acids for any metabolic disorder leading to this jaundice. And you review results of newborn metabolic screen, and you check the urine for reducing substances. You check the urine for bile acids. And there is a role of radiology department as well in the evaluation of babies with conjugated hyperbilirubinemia. One investigation that is done is ultrasonography, ultrasound. Patient should be nothing per oral to increase likelihood of visualizing the gallbladder. And if you do the ultrasound when the mother is feeding the baby, you can actually see the contraction of the gallbladder. And beside doing the ultrasonography, the another investigation is hepatobiliary scintigraphy. For that, you have to pre-medicate with phenobarbital. Dose is 5 milligram per kilogram per day for 3 to 5 days. And after this, you inject a dye into the baby's blood, and that dye reaches to the liver. And from the liver, it reaches from the common bile duct to the intestine. Supposing if the patient is having congenital biliary atresia, in that case, that dye will only be seen up to the liver, and it will not be reaching the intestine. So you can diagnose biliary atresia by HIDA scan as well. And there are certain invasive studies that are done in special cases in which you may do a duodenal intubation. You can go for percutaneous liver biopsy, percutaneous transhepatic cholangiography, endoscopic retrograde cholangiopancreatography, exploratory laparotomy with intraoperative cholangiogram. These are the invasive studies that might be needed in some cases. Now, the estimated frequency of various clinical forms of neonatal cholestasis. If you see idiopathic neonatal hepatitis, 15% cases in which the cause is not known. Extrahepatic biliary atresia, as you can see, 25 to 30% cases of conjugated hyperbilirubinemia belongs to this cause, extrahepatic biliary atresia. Then you have alpha-1 antitrypsin deficiency, 7 to 10% cases belong to this category. Then intrahepatic cholestasis syndromes like Alagille syndrome or progressive familial intrahepatic cholestasis syndrome, that accounts for about 20%. And you have bacterial sepsis as 2% cases, hepatitis and cytomegalovirus, rubella virus 1%, endocrine causes like hypothyroidism or panhypopituitarism 1%, galactosemia 1%, inborn errors of bile acid biosynthesis 2 to 5% cases. So these are the different clinical forms of cholestatic jaundice and its frequency. Proposed subtypes of intrahepatic cholestasis, in which you have bile duct paucity syndromes like Alagille syndrome, non-syndromic, or progressive familial intrahepatic cholestasis, disorders of canalicular transport, bile acid transport, phospholipid transport, disorders of bile acid biosynthesis, and undefined. These are very rare causes of cholestasis. So whenever you are investigating for cholestasis, what are your objectives? First objective is you want to find out whether this patient is having cholestatic jaundice because of intrahepatic cause or extrahepatic cause. Because as we have discussed, if the cause is extrahepatic, then the pediatric surgeon will be the main person who will be dealing with the patient. And if the cause is intrahepatic, then the pediatrician will be the main person. And the second objective of investigating a patient with cholestatic jaundice is that whether this baby is having jaundice because of some treatable disorder or it is because of some untreatable disorder. For example, if the baby is having conjugated hyperbilirubinemia because of sepsis, because of some bacterial infection, it is a treatable disorder. You can give antibiotic and treat the infection and the child will get better. Or the child is having biliary atresia, and you can refer the patient to a surgeon who can do the surgery on that patient, and that is a treatable disorder. So we have to look for it, whether the patient cause of cholestasis jaundice, is it a treatable cause or untreatable cause. And third idea of doing the investigation for cholestasis is to look for liver damage that has already taken place prior to coming to you. And this another reason of investigating a patient with conjugated hyperbilirubinemia is to look for any complications of cholestasis that the child has developed. For example, one of the complication of cholestasis is that the patient develops increased prothrombin time, and that leads to frequent bleeding. Or there is accumulation of bile salts that will lead to frequent itching. Special tests that are done in patients with cholestasis are: you do the X-ray. If you do the X-ray spine, you see the butterfly vertebrae in a patient with Alagille syndrome. And if you do the X-ray skull, long bones, you can look for intrauterine infection. There is calcification. Intracranial calcification can be seen in patients with intrauterine infection like torch infection. Beside this, sweat chloride test is done, and that will be useful in a patient who is having cystic fibrosis as a cause of cholestatic jaundice. Regarding the ophthalmological examination, if you see a cataract in a newborn baby, always consider galactosemia as one of the cause or some intrauterine infection. And if you do the fundoscopy and you see there is retinopathy, that will indicate that possibility of intrauterine infection as the underlying cause. If there is posterior embryotoxin, then Alagille syndrome can be considered. And others, you have a bone marrow examination for Niemann-Pick disease, and bile acids can also be checked. Ultrasound is also a useful investigation in a patient with conjugated hyperbilirubinemia, and you can diagnose choledochal cyst with the help of ultrasound. And you also look for postprandial contraction of gallbladder when the mother is breastfeeding the baby. Ultrasound is done to see whether the baby gallbladder is functioning or not. Then endoscopic retrograde cholangio pancreatography is another special test that can be done when investigating a patient with cholestasis. And the other special tests that are done in patient with cholestasis is liver biopsy. You do the needle biopsy or liver biopsy. In patients with biliary atresia, portal duct proliferation will be seen. In patients with neonatal hepatitis, giant cells will be seen. And in specific disorders, you go look for alpha-1 antitrypsin level also in the material that you have taken out while doing the liver biopsy. Now, one of the, as we have discussed, common cause of congenital conjugated hyperbilirubinemia is biliary atresia. So let us discuss about biliary atresia. It's a progressive scarring of bile ducts outside and inside of the liver that leads to complete blockage of bile flow in the first 3 months of life. If you see on this diagram, this is the normal liver, right lobe and the left lobe, and this is the hepatic duct, and this hepatic duct join together to form the common hepatic duct, and this is gallbladder, and this is the cystic duct and common hepatic duct join together to form the common bile duct, and that common bile duct enters through the duodenum. This is the normal anatomy. What happens in a patient with biliary atresia? This pathway is obliterated. As you can see, and the common bile duct, and the hepatic duct, and the cystic duct, the common bile duct, all are atretic. This is called biliary atresia, and whatever the bile is formed in the liver is not able to reach to the intestine, and that conjugated bilirubin enters into the blood circulation, and the patient presents to you with severe jaundice, usually after the second week of life. Jaundice usually appear in the second or third week of life and progresses slowly. The urine is dark yellow and the stool are clay colored due to fat malabsorption. The liver is grossly enlarged while the spleen is usually palpable. Initially, the child looks well considering the degree of jaundice and hepatomegaly. So if you see a healthy, good weight baby with abdominal distension, liver is enlarged, spleen tip is also palpable, the patient is severely jaundiced, and otherwise the baby is looking active, most likely this will go in favor of congenital biliary atresia. Technetium 99 scan shows failure of dye to be excreted into the intestine and liver biopsy helps establish the diagnosis. As I have already discussed with you, we perform the HIDA scan, by doing the HIDA scan, we can see that the dye, although reaching to the liver, but it's not reaching to the intestine. So by this, we conclude that this is a patient with congenital biliary atresia, and we can also perform the liver biopsy on such patient to establish the diagnosis. Regarding the treatment of congenital biliary atresia, with early diagnosis, surgical intervention in the form of Kasai operation should be considered preferably within the first 8 weeks of life. So this is the important thing, that one should diagnose the congenital biliary atresia in the first 8 weeks of life, and the baby gets operated, because if you do it early, the results are better. What is Kasai procedure? In Kasai procedure, as you can see, the intestine is cut, and one portion of the intestine that is cut is joined, small intestine attached directly to the liver, and the other portion of the intestine, cut portion, joins the intestine other part. So this is how the bile comes from the liver through the small intestine, and this continuity is now maintained afterwards. So this is called Kasai procedure, in which the atretic common bile duct is removed, and you take a part of the spleen and join it with directly to the liver, and whatever the bile is formed enters into this portion of the small intestine and reaches the intestine. This is called Kasai procedure. Kasai procedure performed for biliary atresia that is not surgically correctable, with excision of a distal atretic segment. Rex and Y portoenterostomy is done. Bile flow re-established in 80 to 90% if performed prior to 8 weeks old. So if you perform the before 8 weeks, then in 80 to 90% cases, the bile flow gets reestablished and the patient gets better. Bile flow reestablished in less than 20% if performed after 12 weeks old. But if you perform the same procedure, Kasai procedure, say after 12 weeks, then the chances of reestablishing the bile flow will be less than 20%. So it highlights the importance of diagnosing a baby with congenital hyperbilirubinemia at proper time and treating the baby before 8 weeks so that the prognosis could be better. Success of the operation is dependent on the presence and size of ductal remnants, the extent of the intrahepatic disease, and the experience of the surgeon. Complications are ascending cholangitis and reobstruction, as well as failure to re-establish bile flow. Outcome after Kasai procedure. Short-term and long-term. Bile flow dependent on age at Kasai procedure. Supposing if you do the Kasai procedure at less than 60 days of age, then the 80% chances that the bile flow will establish. But if you perform the same procedure, say after 60 days, between 60 to 90 days, there is a 50% chance of establishment of bile flow. But if you perform the same procedure, say after 90 days of age, then the chances of bile flow is establishment is just 10 to 20%. So it is recommended that one should diagnose congenital biliary atresia as early as possible and get the surgery done before 8 weeks of life. Regarding the long-term survival, 10-year survival where there is no transplant is needed is seen in 20 to 40% cases in US and France, and in 50% cases in Japan. Liver transplantation required for 80%. So in 80% of cases, after this Kasai procedure, usually by the age of 1 year, liver transplantation is done, and it will solve the issue for most of the time. Now, something about the liver transplantation. Survival rates approach 80% at 1 year and 70% at 5 years. So usually children with biliary atresia who have gone through the Kasai procedure at the age of 1 year, if you perform the liver transplant on those patients, then the survival rates are approximately 80%, and survival rate will be around 70% if you do the liver transplant at the age of 5 years. So the ideally speaking, Kasai procedure should be done at 8 weeks of age, and the liver transplant should be done at 1 year of age. Biliary atresia is the most common indication for transplant and may be the initial treatment when detected late, or may be used as a salvage procedure for a failed Kasai procedure. Used early in cases of tyrosinemia. Now, extrahepatic neonatal cholestasis. Beside biliary atresia, the other causes of extrahepatic neonatal cholestasis are choledochal cyst, inspissated bile syndrome, bile duct stenosis, spontaneous perforation of bile duct, cholelithiasis, tumors, and masses. This is the photograph of a baby who is having choledochal cyst. As you can see, there is a cystic appearance of the common bile duct. Alpha-1 antitrypsin deficiency is one of the cause of cholestatic jaundice. Alpha-1 antitrypsin makes up 90% of alpha-1 globulin fraction. Biopsy shows hepatocellular edema, giant cell transformation, necrosis, and pseudoacinar transformation. Biopsy also shows accumulation of PAS-positive diastase-resistant globules in the cytoplasm of periportal hepatocytes. Varying degrees of fibrosis correlate with disease prognosis. Intrahepatic cholestasis syndromes include several diagnostic entities. Biopsies shows cholestasis may show paucity of intrahepatic bile ducts, giant cell transformation, and/or fibrosis. Intrahepatic neonatal cholestasis, paucity of intrahepatic bile ducts. Examples are Alagille syndrome, non-syndromic. Alagille syndrome. In 1969, Alagille et al. First reported patients with idiopathic bile duct paucity and similar clinical features, including congenital heart disease. In 1973, Watson and Miller recognized a syndrome that included pulmonary artery abnormalities, neonatal liver disease, somatic anomalies, and a familial tendency. Its coined term arteriohepatic dysplasia. In 1975, Alagille et al. Published extended observation in 15 patients. Chronic liver disease, characteristic facies, systolic murmur, vertebral arch defects, mental retardation, hypogonadism, and family history. Now, therapy of neonatal cholestasis. If you know the cause, the best thing is to treat the cause. As I have mentioned, that supposing if you diagnose someone as having neonatal cholestasis because of bacterial hepatitis, you give antibiotic and treat the bacterial hepatitis. Or if it is because of biliary atresia, you get the Kasai procedure done. So therapy of neonatal cholestasis depends. If you know the cause, you give the specific therapy for that cause. Beside this, you also give supportive treatment. For example, as the patient's bile salts are not coming into the intestine, so there is malabsorption of fat. So for that, you give medium chain triglycerides to the baby in the diet, and vitamin A, D, E, and K. These vitamins get decreased in the blood because they are not metabolized properly in patients with congenital biliary atresia or patients with cholestatic jaundice. So you have to give compensation for that in the form of by giving orally vitamin A, D, E, and K, and medium chain triglycerides in the diet. These patients with neonatal cholestasis also presents with pruritus, hyperlipidemia, cholestasis. To decrease that cholestasis or pruritus or hyperlipidemia, you may give certain medications. For example, cholestyramine 250 to 500 milligram per kilogram per day, phenobarbital 3 to 10 milligram per kilogram per day, ursodeoxycholic acid 10 to 20 milligram per kg per day, and rifampicin 10 mg per kg per day. These are the drugs that are used for treating the cholestasis, pruritus, and hyperlipidemia. And regarding the medical management, nutritional support is provided to the baby, and treatment of pruritus is done. Choleretics and bile acid binders are given, and as children with this sort of jaundice may develop portal hypertension, so one has to manage the portal hypertension and its consequences as well. Regarding the nutritional support, adequate calories and protein should be provided to the baby, and supplement calories with medium chain triglycerides are given, and one has to maintain level of essential long chain fatty acids in the diet, and treat and or prophylaxis for fat soluble vitamin deficiencies. You give vitamin A, D, E, and K to such patients. Beside this, supplemental calcium and phosphate when bone disease is present is given. Prophylaxis for zinc deficiency is also being given, and zinc is provided in the diet. And low copper diet as poorly excreted, so low copper diet is given. Sodium restriction when ascites is present. And if the baby is having pruritus, you give bile acid binders like cholestyramine and cholestyramine, ursodeoxycholic acid, phenobarbital as a choleretic, naloxone, rifampicin. These all are the drugs that are used for treatment of pruritus. Management of portal hypertension and its consequences. Variceal bleeding. In this, you do the fluid resuscitation. You give blood products like plasma or whole blood. You do the sclerotherapy. Balloon tamponade can be done. Portovenous shunting and Indral, that is propranolol, can be given in patients who are having variceal bleeding. If the patient is having ascites, you restrict the sodium. You give diuretics like spironolactone and furosemide. You give albumin, and paracentesis is also needed sometimes. And if there is thrombocytopenia, then you manage it by giving platelet infusions when clinically indicated. Neonatal cholestasis, that is conjugated hyperbilirubinemia. Messages, take home messages, refer urgently. So this brings to the end of the lecture. If you have any questions, then you can ask the questions and I will be happy to answer those questions. Okay. कोई questions नहीं है? As there are no questions, then it's all over. Thank you. Allah Hafiz.